the complications, so on and so forth. Nothing more than that. It's going to be a pretty basic class. I just share my screen now. And as any of my classes go, whenever you have a doubt or you're trying to answer my question, just put it in the chat box. I'll make sure I'll answer it as and when possible. Okay. So management of hemorrhage, it's one of the emergencies. We all know that. So causes of hemorrhage, we all know the most common cause trauma. Then you have your DIC, which is some coagulation disorder. Again, most common in non-traumatic patients, variceal bleedings. And then this is a cancer eroding vessels. Is there any other cause that I've missed out? I've missed out a lot. Can you say one or two? I've missed out a lot of causes. It's just so I can warm up the session. Okay, ICH, PPH, yes. Postpartum hemorrhage, very high mortality in pregnant women if it's not properly managed. ICH, intracranial hemorrhage, though it does not cause a life-threatening hemorrhage, the complications of ICH per se are life-threatening. Upper GI hemorrhage, that is what variceal bleeding. So upper GI also is variceal bleeding. So that also can occur. So these are some of the common causes. Now remember, I always, yeah, SH, that all comes in the intracranial hemorrhages. As I always tell, which you have trauma. Trauma is the most common cause of hemorrhage. Okay, so which part of your body when gets fractured or something happens is going to cause massive hemorrhage? So that is a common question again and again asked. I'm telling you, like if they say this fracture, if they say this bone fracture, then there's a high chance the patient is losing a lot of blood, even he might not manifest it yet. So which part is it? So that is what is given here. So pelvis, I've repeated it so many times. Pelvis is a big black hole. Whatever goes in, it's a huge space. So whatever blood goes in is going to stay there for a very long time. Any pelvic fracture, any long bone, femur fracture, especially, can cause a large hematoma, can cause massive hemorrhage. This is something that we have been taught when you work in your ED. Whenever a patient comes with suspected pelvis fracture or femur fracture, you have to estimate a blood loss of 1500 ml and pelvis 3000 ml respectively. If there is a pelvis fracture or if there is a trauma to pelvis, if there is a femoral fracture, especially a femoral fracture, you're going to blindly estimate 1500 ml. You're going to make sure you cross match and keep the bones blood ready. Okay. And then abdominal trauma. Again, any abdominal trauma is going to cause massive hemorrhage. Can ICH cause massive hemorrhage? So people have said ICH, people have said SH. Can ICH or SH cause massive hemorrhage? It's a yes or no question. You can either cause or you cannot cause. No, because it is a small box, it is contained. The space is contained, so it cannot cause a very large hemorrhage. Rather, because of increased intracranial pressure, it is going to cause other side effects. The blood loss per se is going to be minimal when compared to pelvis or abdominal trauma. And then AAA, we dealt it 2 days back. Rupture AAA can cause massive hemorrhage. Splenic injury. Splenic injury is one of the very common causes of massive hemorrhage. Okay, especially in sportsmen following which infection? So this is again commonly asked, which rupture? Splenic rupture is most commonly following dash infection. So this is why contact sports must be avoided. Contact sports must be avoided in people who are having this infection for the next 1 year in fear of splenic rupture. Yes, infectious mononucleosis. These are all some other points. It's not exactly hemorrhage, but they're all infectious mononucleosis. Whenever you're susceptible with, when you're affected with infectious mononucleosis or EBV, you're getting hepatosplenomegaly, especially a massive splenomegaly. The spleen is easily susceptible to rupture, especially since it's known as kissing disease. It occurs in teenage rugby sportsmen. And whenever this happens, you're going to get rupture of spleen. That AAA is abdominal aortic aneurysm. So that is what AAA means. And then again, this is one table that we all try to memorize, we always fail. So this is determining the estimation of blood loss as to how much percentage of total blood loss is lost. So I would say focus on the heart rate if it's a theoretical question. Focus on the heart rate if it's a theoretical question. If the heart rate is 100 to 120, it's class 2, 120 to 140, class 3, and greater than 140, class 4. So there is a basic, if they ask us a theoretical question, focus on the heart rate. And if you want to remember something else, remember the mental stages. If the patient is anxious and confused, it's going to become class 3. Confused and lethargic, class 4. If the patient is lethargic, non-responsive, they automatically go into class 4 of hemorrhage. This is all pure theory. That's why I'm not going deep into this. This you can take away, memorize it whenever you want. There are two factors that are most important in clinical management in this table. One is heart rate, the other one is urine output. These both are very important in management of hemorrhage. Okay. Remember these both for management of hemorrhage. For theoretical aspects, heart rate is more than sufficient. Usually they give you a pulse rate. And even so, if they ever say pelvis or femur, it's either class 3 or class 4. Think like that as well. This is a pakka theory topic, this table. If anyone wants, you can take it from net as well. So again, a 50-year-old man who's sustained RTA injury in his thigh came into the ER. On examination, he's conscious. Pulse rate is 120 beats per minute. BP is 90 by 60. SpO2 is 95% under room air. What is the next best step? Yes, it's always ABCD. It's always ABCD. There's nothing short of that. Okay. So ABCD. In this, the C plays the most important role. You're going to secure IV access, two large bore IV needles. So it's either 16 or higher, 16 gauge or higher. 16 gauge is which color? Which color IV needle are we speaking about when I say 16 gauge? When I say 16 gauge, which color Venflan am I speaking about? 16 is corresponding to which color? Any idea, any guesses? Random color? Yeah, so 16 gauge is green, okay. Gray becomes a higher gauge. Gray is very long. Its orange is even longer. So we usually secure a green gauge, green line, or a 16 gauge line, okay. And then you're going to do an O2 support that is plus or minus depending on the respiration. You're going to connect them to monitor. Apart from this, you're going to catheterize the patient. Why is catheterizing the patient important? Especially, why is catheterizing the patient important? Especially in case of a hemorrhage. One is urine output, and the other one is also urine output, especially urine output and the color of urine. So the urine color is very important. Okay. When do you say, I have a case of RTA? When do you not catheterize a patient? When do you not catheterize a patient? Pelvic fracture, hematuria, urethral injury. Yes. Whenever you say it's blood at the tip of meatus, this is usually they say. So pelvic fracture, hematuria, urethral injury, you're not going to do. Pelvic fracture, even if pelvic fracture, if the patient does not have urethral injury, you're going to catheterize. Blood at the tip of meatus is a sign. Blood at the tip of meatus. So this says it's hematuria. Okay. So this is a case where it says hematuria. So catheterization of the patient is done. Urine output and color of the urine is monitored continuously. Then again, fluid challenge, crystalloids, colloids. As I said yesterday, so what do you give, crystalloids or colloids, which is preferred, especially in resuscitation? And if crystalloids, what is the specific crystalloid that you use? NS, yes. So you're going to use NS, irrespective of what you do, NS. So you're going to use NS, okay? DNS is not all preferred. You're going to take a CBG. If it's low, you do you do urinary catheterization, hypertension crisis? How do they present in hypertension crisis? Depends. That hypertension crisis is a very broad term. If they are in CKD, pulmonary edema, you're going to do urine catheterization. If they are in an ICH state, they're not able to go for urine, you'll do catheterization for the initial period. Irrespective, urinary catheterization becomes a standard of care, especially for the first 24 hours, where you have to monitor urine output irrespective. And then I'm extremely sorry, Shweta pointed out correctly. 18 gauge is green. I'm sorry, 18 gauge is green, okay? 18 or higher. Usually we try to secure a 16 gauge line. Why do I always say 16 or higher is because these are every Venflon has a color coding. Each color coding vent has a rate of flow. That is, you say it is drops per minute. Drops per minute. It's like the flow rate through the vent. Higher gauges, that is, when we say higher gauge vent, which means the number decreases. So as the number decreases, the flow is high. So that is why we always use a higher gauge vent. Okay. And then any trauma case comes, you're going to send for the routine CBC, RLE, blood grouping typing, cross-matching sample. All of this is going to be done. In this, the most important is blood grouping typing, cross-matching test sample. And then in a trauma situation, acute trauma situation, we are going to use EFAST. EFAST is going to be, can anyone expand phased focused? Yeah, can anyone expand phase T fast? What does fast stand for? I'm hoping you're all typing. Okay. Okay, so it's assessment using sonography in trauma. So it's focus assessment using sonography in trauma. Okay, using sonography in trauma. So that is fast, and E stands for extended. Okay, so it's extended focus assessment. So why was the term E added is, so usually whenever you do try an E fast, so this is your abdomen, right? You first check your hepatorenal pouch. Hepatorenal pouch is one of the most dependent spaces where fluid collects. So you check your hepatorenal pouch, then you check your hepatosplenic pouch, I mean, renorenal pouch. Then you make sure you check your ascitic, your abdomen to check for any free fluid. So this was initially done, and then most important, you check your bladder. So these are the four sites where you actually check. But what happened was they actually added another view called a substernal view or a sternal view where you can check your cardiac window. So this is extended. Apart from this, you can also check your thoracic spaces to check for hemothorax or pleural effusion, anything. So this is EFAST. This is extended focus assessment using sonography in trauma. So this is EFAST. So this is done in an acute setting. This is done by medicine doctors, by emergency medicine. This does not need a radiologist. So whenever they do expect you to understand EFAST, they are going to give you a picture of free fluid in the USG. I have added a picture. So that is a free fluid in USG picture. You have to recognize it and between which organs it's present as well, because this is you're going to do it when you're an intern in EFAS and ED. So it's actually done in ED by us. Okay. And then USG or CT is for more detailed evaluation. Can you please pardon me fast? I'm sorry. I can just rephrase. I don't get it. So EFAST, maybe I'm trying to explain it again. Okay. So EFAST is for extended focus assessment using sonography. The EFAST is going to cover usually fast covered only four areas, but now we have added some more areas. That's why it's known as extended. This is usually done by emergency medicine doctors, or surgeries. This does not need a radiologist. It's very important to know that. So now what are you going to do? The initial site that you always keep the probe is right side, hepatorenal pouch. So this is where you always keep your probe first, followed by your spleen, followed by your bladder, and then you look for free fluid in the abdomen. And then if after that, you're going to check your cardiac window where you can see pericardial effusion, you can see all that, and then you're going to pass it along your thoracic cavity. On doing so, you can see any free fluid present in either thorax. So either thorax. So this is EFAST. Okay. And then what does MTP mean? In a trauma, what does MTP mean? MTP. Massive transfusion protocol. So it's known as massive transfusion protocol. So whenever you get a case of trauma, you're going to think, do I need more than 2 units? Do I need more than 3 units of blood for this patient? In doing so, you have to activate something known as massive transfusion protocol. This is not done in major trauma. See, there was only one case where I've ever seen MTP done. That was in a case of PPH. In a case of severe atonic PPH, we had to do massive transfusion protocol. I was the intern running for blood, so I knew what they were giving. I knew what to expect. So this was massive transfusion. That is the only time when I had it activated. Other than that, even we had a case of hand decapitation in ED. We didn't actually activate massive transfusion. There's a very strict criteria as to when you do. So it depends from hospital to hospital, from blood bank to blood bank. But yeah, so this is massive transfusion. You have to ponder. So you have given ABCD, you have given IV access, you have secured large bore IV needles, you have given them crystalloids, you have taken blood samples, you have done a EFAST. It's either positive or negative. Now you're going to see, do I need to activate massive transfusion protocol? So this is what you're going to see. Okay. So this is what we have dealt with right now. This is the initial management of hemorrhage. With this, we are moving on to something else. I'll come back to it. So, a 45-year-old man was undergoing cardiac ablation through femoral vein. As a doctor was completing his procedure, he felt resistant while pulling the catheter. Within minutes, a mass is seen developing. What is the next best step? What is the next best step? You are doing this procedure. You're pulling the catheter. Okay. So Shreya said ABCD. This is one place where it's CABC. So this again, this is one place where it's CABC. C stands for compression. I'll I'll tell you why I actually included this question. So this was a question when I was practicing for PLAB exam. I actually got this question here. So what happened was the options were apply compression, start IV fluids. I'm eliminating the other three options. So it's apply compression, start IV fluids. So me saying all this, what did I choose? I started IV fluids. But logical answer is you apply compression because there is an expanding hematoma right in front of you, or there is massive hemorrhage right in front of you. So the first thing you do is you go put your hand there, you apply a gauze pad, and you compress the space. So that is what is CABC. Sometimes it's compression followed by ABC because compression itself is going to be the most helpful thing you're going to do for the patient. So compression C and followed by ABC. So sometimes it's CABC. Anticoagulation, maybe it can even be a splenic rupture, I mean vein rupture, an artery was it, anything, it doesn't matter. What I'm saying is compression is first. So that's what they're trying to tell. Compression is first. Now moving on, again some important pictures. I always show it in my lectures. So what is this? Let's assume A, B, C. What is A? A, B, C. Pelvic. A, no, I don't want you to jump. Let's start with A. Someone has said pelvic followed by fracture. It's pelvic binder, yes. So this is a pelvic binder. So we'll just deal with pelvic binder, then move on to B. So what is a pelvic binder? Pelvic binder is, it can be in many forms. This is the most classical or rather most useful form that we're going to do in our hospitals. So they take two bed sheets or they take two towel or two bed sheets. They wrap it tightly around the pelvis. So this forms a pelvic binder preventing further hemorrhage. This is life-saving in so many cases. Whenever you get a case of pelvic trauma to your ED, the patient is going to come with a pelvic binder or you're going to apply a pelvic binder for the patient. The same goes for femur as well. You're going to tightly wrap it around it. So this is very important. You do apply a pelvic binder, okay? Application of pelvic binder for pelvic trauma is most important step you can ever do because this is a compression step. You're going to compress the patient there, you're going to press it there. So we'll move on to B. So what are the signs? Yeah, so this is Cullen sign. And what is the other one? Like this is the flank. Okay, this is a flank. The picture has been cropped. So what is that sign called? Cullen sign. What is the other one?
Laceration.
Yeah. So what do these indicate? These are not specific for pancreatitis. Someone actually commented it before. They are not specific for pancreatitis. They are specific for intra-abdominal hemorrhage. There's a specific for intra-abdominal hemorrhage or trauma there. Okay. They're not specific for pancreatitis. They're not specific for either one organ. Actually, they're not specific for any organ. They're just specific for intra-abdominal bleeding. That's all. They're not specific for any particular organ. We do see it in case of necrotizing pancreatitis, in case of kidney hematoma, in case of retroperitoneal hemorrhage. We do see that, but they're not specific for any organ. They're specific for hemorrhage, especially retroperitoneal hemorrhage. So yeah, let's go step by step. There's no hurry. Let's go step by step. I finish the dialogue, then we can do. So this again, Shreya already answered. It's a USD picture. It's not a fast picture. It's a USD picture. So what are you seeing there? I'll again label it 1, 2, 3. Let's not confuse it with A, B, C. Let's label it 1, 2, 3. So 1, 2, 3. So what is 1? What is 2? What is 3? One, I think Shweta's answered liver. Any other answers? Okay. So one is liver. Rather, it's a tip. It's a very small part. Yeah. Three is kidney. And two, whoever answered blood, you don't know it's blood. It's fluid collection. It's free fluid. That's all. You don't know it's blood or fluid. Ascites, you don't know that. It's free fluid. So this is free fluid. Okay. So this is a case of positive E fast. So this is the most dependent part, and this is a case of positive reflux in the hepatorenal pouch, or the Morrison's pouch. Okay, so this is a fluid in hepatorenal pouch. As you can see, liver, kidney. So between liver and kidney, there is free fluid. So this is hepatorenal. So hepatorenal pouch, this is free fluid, a case of positive EFAST. Okay, and then this I know is the most mind-numbing question along the whole thing. Why do you need IV fluids? Or fast? See, both are same. Fast and USG go hand in hand. Fast is using an USG. So like they both are similar. They fast uses an USG. So it is an USD picture. You don't know if it's fast or not. So why do you need IV fluids or blood? Compensating for the loss, maintaining BP, maintaining perfusion, especially for keeping mean arterial pressure greater than 60. So this is the main aim, compensating for the loss, maintaining BP, maintaining perfusion. Okay. So why blood products? So why are we giving importance as to when should blood products be transferred? Why should you transfer? So plain IV fluids, hypovolemia, pulmonary, hypervolemic states, pulmonary edema, hypothermia can be precipitated, dilutional coagulopathy can be precipitated, electrolyte imbalance. So dilutional coagulopathy, why do you say dilutional coagulopathy? The clotting factors are going to be diluted in the amount of NS you're going to put. Probably 2 liters, 3 liters is going to get diluted. So that is why dilutional coagulopathy is precipitated. And then an electrolyte imbalance. What electrolyte imbalance do you see if you're going to keep on resuscitating using NS? What electrolyte imbalance is going to occur if you're going to keep on using NS for that? Yeah, not sodium. Sodium is very rare to occur. You do get hypokalemia. You get hypokalemia. Hypernatremia using NS is very rare. Okay, but hypokalemia is highly possible. So that is why usually in our third bottle we actually put 1 ampule of potassium in case of resuscitation, but hypokalemia is more possible. Okay, so when do you transfuse blood? Uncorrected refractory hypotension greater than 5 units or 5 units lost, major trauma or greater than 10 units anticipated, like for example, a pelvic or intra-abdominal or a femur fracture, a penetrating wound, a positive EFAST, and systolic blood pressure less than 90, heart rate greater than 120. So this puts you in class 3. So class 3 or higher trauma. So all of this is going to need blood transfusion. So for blood transfusion, what do? You always cross match. You're going to take the patient's sample in an EDTA tube and a clot activator tube. You're going to give it to the blood bank. They will run blood grouping typing. They will cross match blood and blood products together. So blood and blood products must be transferred, not just blood, blood products as well. So what are the blood products that you know? Whenever I say blood products, what am I trying to mean? Blood products. What are the blood products present in a blood bank? So blood is either, just to clarify, blood is either whole blood or packed RBCs. Okay. The use of whole blood is almost gone. We are using packed RBCs nowadays. Whole blood is very rarely used. And then the blood products, yes, thank you. Everyone have been answering. FFP, you have your SDP, yes. Cryoprecipitate, yes. SDP is single donor platelet. FFP is fresh frozen plasma. Fresh frozen plasma. Cryoprecipitate. Yeah, so these all have been answered. So all of this is present apart from that factor 8 concentrate is available. Factor 8 concentrate is available. Platelets are available, just platelets, nothing else, just platelets. These are also available. So yeah, these are all the products available. So blood should be warmed before transfusing because blood is stored in minus degrees. So you need to warm the blood and blood products before transfusing. Blood products should be used whenever possible as PRBC lacks coagulation factor. See, if you're going to transfuse only PRBC, you're again going to get dilutional coagulopathy. Okay. This dilutional coagulopathy is going to be very dangerous in case of just PRBC transfusion. PRBC transfusion has very, very minimal clotting factors, rather it has none. So you're going to transfuse platelets, FFP, PRBC in the ratio 1 is to 1 is to 1. So this is going to happen irrespective. Okay. So this is the transfusion protocol, 1 is to 1 is to 1, not always followed, but this is the ideal protocol. So we have PR, I'm sorry again. Concurrent. Okay. So we have your PRBC, you have your SDP, you have the FFP, you have your prothrombin concentrate, factor 8 concentrate, cryoprecipitate, all of these are available. All of these have different functions. PRBC is basically RBCs. Platelets, you all know. 1 unit is 300 ml. FF, actually, it's either 300 or less. You even get 300 less ml, you can get 325. It depends on blood banks, but 300 ml is standard. And then fresh frozen plasma is what we usually get. You don't get it as units, you get it as single packets. When you combine 6 to 12, when you combine six packets of fresh frozen plasma, you get 300 ml. So this also happens. So this is fresh frozen plasma. So these both are most commonly used. And then apart from that, we use platelets. Whenever we say just platelets, it's RDP, which is random donor platelets. SDP, single donor platelets, is very rarely used in case of trauma. Single donor platelets is more commonly used in chemotherapy or cancer related or cardiac surgery where you need massive platelet transfusion. In those cases, you need single donor, so there is a very, very minimal chance of transfusion reaction. So that is why we even narrow it down further. So all of this happens. So these are the blood products that everyone must be aware of. Because blood transfusion has become obsolete. It's blood and blood product transfusion now. Never say just blood transfusion. It's blood and blood product transfusion. Blood products are the ones being most commonly used. Again, this was already a slide that I've displayed in one of my previous classes, but let's go again. I've named it from right to left. So A, what is A? It's given in the packet itself. What is A? No, A, I've named it right to left. I just want to see everyone is awake. So what is A? Ayush is sleeping Naina. Right to left. Harjot has answered correctly. It's an O negative PRBC, especially. It's an O negative PRBC, not just tranexam. It's not just the PRBC. Again, Shreya, Jay, Kirti, I'm going from right to left, not left to right. I just want to make sure everyone is awake. So it's right to left. PRBC is an O negative PRBC. Okay. What is the significance of O negative PRBC? Again, don't jump. What is the significance of O negative PRBC? You can transfuse it to any patient. It's a universal donor, yes. So that is why O negative PRBCs are in severe short storage. It's very rare to get it other than trauma. But yeah, we do have O negative PRBC available in every blood bank. And it's a universal donor. You can transfuse it to any patient without fear of cross matching. Okay. So this is done in case of MTP or if there is massive hemorrhage. This is usually done after you get a red seal or a hemorrhage seal from ED. You have to apply for it separately. And then D, someone has actually told it, it's FFP. So whenever you get a yellow bag, which is slimy in nature, it's an FFP bag. Platelets is a bigger bag, which is less colored and even lesser volume. So this is an FFP bag. So FFP again, it's a fresh frozen plasma. It's rich in clotting factors. Always transfused as 1 is to 1 is to 1 ratio. So remember that again. So FFP is again done. So we have covered that. And then what is C? What is C? Apheresis machine. Yes, it's a plasma apheresis machine. That is to get your platelets, to get your plasma from a patient directly, you're going to do a apheresis machine. You can either pass the blood or you can pass the human directly. So when you do take direct IV connection and put it in the thing, you use this apheresis machine. For blood collection, you do have a simpler version. This is an apheresis machine to collect your FFP, to collect your SDP, you collect your platelets here. All of this is done using one machine. So it comes, it splits according to products, and it again cycles it back in. It only cycles the empty plasma and your blood inside. So that's what happens. And D is your tranexamic acid. It's an antifibrinolytic. Okay. So it's an antifibrinolytic. So this is going to strengthen your clot. It's going to promote clot formation. So tranexamic acid has become a norm in trauma. Whenever you get a trauma case, first bottle NS, second bottle with tranexamic acid 1 gram, third bottle 1 ampule KCl. So this is what we usually do. Okay, not just PPH. In all trauma cases, this has been implemented now. As I said, first bottle NS, first bottle pain NS, second bottle NS plus 1 gram tranexamic acid, third bottle NS plus 1 ampule KCl. So this is what we usually prefer in case of trauma, because tranexamic acid is going to be antifibrinolytic, probably reduce your hemorrhage. This has become the key in cases of dysmenorrhea, menorrhagia, and then you're going to also use it in cases of postpartum hemorrhage, where tranexamic acid is very important. And then, yeah, PCC is an apheresis machine, or plasma apheresis. So it's going to third bottle is KCl, 1 ampule KCl, so that you don't get, because you're transfusing a lot of fluid, so the chance of hypokalemia is high. So you're going to give KCl to balance it out. There's no potassium in the NS that you're transfusing. There is no potassium. So you've already given 1,500 ml of fluid with no potassium. So they are bound to get hypokalemia. So C is the apheresis machine. So what it does is it takes your blood, it separates into components. It's going to give you platelets, it's going to give you plasma, and then it's going to cycle back the RBCs and plasma back into your blood body. So this is an apheresis machine for separation of components. Okay. And then when to trigger, I've already given this. Always remember the shock index is most important, followed by ABC score, or shock index followed by RAB score. Remember this. So these are criteria where shock index greater than 1. Shock index is the most important thing that you have to remember. Heart rate by BP, by systolic BP. If it is greater than 1, you're going to activate MTP, or it is a shock index. This is what you say, it is shock index. This indicates there is going to be a massive hemorrhage, or there is a massive hemorrhage and needs massive transfusion protocol. Though this is, again, this is highly variable, depends from place to place. But standard criteria says use of shock index is the most important. Okay. So the aim is MTP. So this is the MTP protocol. You trigger a plan, you organize a team, you give 1 gram of tranexamic acid, you test thoroughly, you transfuse you to the right target. This happens transfusing to the wrong patient, so you transfuse it to the right target. Temperature, prevent hypothermia, terminate, decode. So these are the 7 steps. I'm not going to go into deep about everything. I'll just tell you the overall thing. So you see a patient, you think I have to activate MTP, you're going to activate MTP. Before that, you're going to make sure you have run your CBC, RLE, and coagulation profile. Yeah, make sure you have run that. You have given that for lab, okay? And then you're also going to take a VBG rather than ABG, a venous blood gas. In doing so, you can see some parameters. And then you see a massive bleeding. Shreya didn't attend yesterday's class, I think. She was the one who asked for the sepsis algorithm and actually put it, and she didn't attend yesterday. So algorithm, I've given it for 2 pages, so don't worry. So massive bleeding, you're going to attending physician, see criteria. So blood bank again, blood bank is going to receive your massive transfusion protocol criteria. You're going to receive it. And then what they're going to give you is 4 units of O negative PRBC. But this again changes from place to place. No blood bank is going to give you 4 units. They will say, I will give you 1 unit of O negative PRBC. They will give you FFP how much ever you want, platelets how much ever you want. O negative PRBC is very rare. So they will give you 1 unit of O negative PRBC, followed by which they will cross match and keep it ready. So in doing so, you actually cross match actual PRBC rather than just the oh, sorry, Yash. So rather than just the O negative PRBC, which again has a higher chance, you're going to cross match it and give it properly. In doing so, the chances of transfusion reaction is going to reduce. Okay. So emergency laboratory, MTP activation, blood bank, first package. So first package means you're transfusing about 4 units, followed by plasma, followed by platelets. So it's like a box. Including this, you're going to have tranexamic acid. So this all comes into one package. Once you finish this takes about 6 hours to transfuse. 4 units of PRBC, 2 units of plasma, 1 unit of platelets. It's going to take a lot of time to transfuse this. It almost takes 3 to 6 hours it actually takes more than 6 hours to transfuse this. Meanwhile, you're going to give a tranexamic acid, okay? And then the second package of transfusion is going to be again, it's either going to be your O negative or plasma. So what happens is, usually after the first package, you see the hemorrhage is actually controlled. Usually people don't go for a second package unless until you're in a foreign country or something like that. Here, you usually try to control the hemorrhage using the first package. By the time the first 4 units are transfused, you would have shifted the patient to OT in case of a massive hemorrhage. So that's how effective we are. So it's an O negative PRBC. Again, as I said, very rare. Remember, not whenever you do look out massive transfusion protocols on the internet, they give you O negative. Only one O negative comes, the others is actually cross-matched. At every stage, you can give tranexamic acid, additional dosage of tranexamic acid. Never forget that. It's very important. Tranexamic acid plays a major role. And then subsequently, it's going to depend on something known as ROTEM. Okay. See, PRBC undeniably is going to be based on what the attending or doctor decides. But the FFP and plasma or platelets or concentrates is going to be determined with blood bank. They're going to do something known as ROTEM, and they're going to say how much coagulation profile is defective, how much coagulation profile has defected, or how much it has deviated because of transfusion, because of our IV fluids. They'll check how much coagulation is needed, and they will give you that amount of FFP and that amount of concentrate. So that is ROTEM. I have covered it in different slides. I'm just giving you because you get an overall picture. Usually, it takes more than 6 hours to transfuse one project. 30 minutes all is very rare. So don't worry about it. So complications of MTP. Give me a reference. You just type MTP, you're gonna get this slide. This there's like a national algorithm in UK. So I took it from UK side. I've covered ROTEM in another slide, don't worry. So complications of MTP, hypocalcemia, the most dreaded complication because citrate toxicity. Citrate is gonna chelate calcium, and then calcium chelation, because of which hypocalcemia is going to precipitate. There is going to be hyperkalemia. Why is there hyperkalemia? Any clues, any guesses as to why hyperkalemia? Cell lysis, yes. Whenever they give you an old RBC packet or an stored that it was obtained a long back ago, you're gonna get a cell-lysed packet. So this is gonna be high in potassium, okay? And then you're gonna get hypothermia. Hypothermia is very common because all our blood and blood products are stored in minus degrees. And then dilutional coagulopathy is that is improper transfusion. You only transfuse PRBC without blood products, you're gonna get coagulopathy, the patient is gonna go into DIC. And then acidosis. All of these are common, okay? Hypocalcemia, and hyperkalemia are the most important, repeatedly asked. Hypocalcemia and hyperkalemia, most common, most important, most repeatedly asked. So the reactions, the delayed, we're not going to talk about now. Acutely, the first thing is a mismatch transfusion with O negative rare, but mismatch is highly possible. Now let's assume it's a case of A negative with KEL antibody. So this is something that I've encountered again. So it's a case of PPH, A negative. You don't get the blood, very difficult. You manage with blood and blood products. PRBC takes a lot of time to cross match. So mismatch transfusion is possible. Now let's assume you started transfusion. That is, you have given less than 10 or 15 ml of blood to the patient. The patient develops anaphylaxis. What does the patient have? So you have transfused 15 ml or less than 15 ml of blood. The patient develops anaphylaxis. What condition does the patient have? Not Charlie. I'll explain Charlie how they ask. So they have something known as IgA deficiency. Okay. Yeah, it's an IgA deficiency, especially. So this is again is a classic scenario where they say a previously healthy normal woman or normal man comes as a case of trauma. You have transfused less than 15 ml, or you just immediately started the transfusion. The patient develops severe anaphylaxis, but you have transfused A positive. So he's A positive. You have actually transfused A positive. So what happens is the patient has IgA deficiency. The PRBC is going to contain IgA. So when you transfuse, the patient is going to get severe allergic reaction. So this is what they usually use in question STEM. IgA deficiency, this is one thing. Blood transfusion, anaphylaxis, IgA deficiency, don't forget this. Then acute hemolytic transfusion reaction. This is one of the reasons why you catheterize patients. Hemolysis, you can see in urine color. It's gonna change it. It's gonna darken. Apart from that, you're gonna have febrile reaction. So all this is possible. So febrile non-hemolytic reactions, TRALI is transfusion-related acute lung injury. The patient will become dyspneic, saturation will drop. Okay, and then TACO. TACO is transfusion-associated cardiac overload. So when you say cardiac overload or circulatory overload, cardiac overload, the patient is going to develop pulmonary edema. So this is what is going to happen. Apart from that, allergic reactions. And then as it always goes with anything, you can get bacterial sepsis or anything. Hypocalcemia, hyperkalemia, most common. Hypocalcemia, hyperkalemia. Dilutional coagulopathy, hyperthermia is also seen. Okay, so these are the acute complications. Remember this IgA deficiency, commonly asked in exams. If they want you to pick TRALI, they will give you a case of desaturation. If they say bilateral crepitus are here, pulmonary edema, TACO. If they have heard, if they say urine turns dark, acute hemolytic. If they say the patient is having clear urine but having it's febrile non-hemolytic transfusion reaction. So this is how you pick out questions and answers from your question stems. Okay. So I hope I'm clear. I hope I didn't go very fast. So this is how you pick up question stems. I hope I've clarified that 5 things and when you pick up. So this is like theoretical as well. So I've just covered it. Okay. So transfuse. So everything is after transfusing blood. Okay. You're transfusing blood, everything happens later. If he gets anaphylaxis, suspect IgA deficiency. Okay. If he gets if he's after transfusion, immediate anaphylaxis, IgA deficiency. If the patient has developed dark urine plus or minus fever, you suspect hemolytic reaction. And usually they also say the laboratory show increased bilirubin. It's usually shown, okay, it's usually given, okay. Then the patient desaturates, then you're going to think TRALI. The patient has decreasing saturation, but has crepitations on bilateral creps, indicating pulmonary edema. So this will indicate TACO. Okay. And then let's assume the patient is being transfused. He develops fever, clear urine in the catheterized bag. You're going to suspect febrile non-hemolytic reaction. And then I can still go on. So the patient develops DIC, think dilutional coagulopathy. Then if the patient develops twitching periorally, numbness perioral paresthesia, twitching, muscle spasm, paresthesia, twitching, muscle spasm, you're going to think hypocalcemia. Okay. So this is what after transfusion, all the side effects and what you're going to think in an exam or in real life, however you want, you can take it. So this is the summary of reactions. Okay. Hope this is clear now. Okay. Moving on, ROTEM. ROTEM is also known as rotational thromboelastometry. So they take a sample of blood, they run it through a machine known as a ROTEM machine. ROTEM can be divided into extem, so on and so intem, extem. Don't forget that. ROTEM, rotation. What was the bluing of blood? Eh, I don't know what is bluing of blood. They take a sample of blood. Are you thinking about ROTEM? Okay. So they take a sample of blood, they run it through a machine. The machine spits out an answer. So this is going to be your answer. So they give it like a graph. So it's like this graph. Okay. They give it like this. So it comes like the machine displays a graph. In doing so, you actually get how many coagulation factors, how many platelets, fibrinogen clots are present, if fibrinolysis is happening, fibrinolytic inhibitors are present. So you get an average reading as to what all is present, what all is absent. Based on this, they either say the clotting factors are very less, so take a prothrombin from concentrate next. This is possible. Or then they say fibrinolytic enzymes are less, give one more tranexamic acid. Or they say your coagulation factors are completely less, take FFP, take platelets, and go. So this is how they usually the blood bank gives us. So this is one case where the blood bank gives us. They say this is all less. especially in a massive hemorrhage, make sure they run Rotem. So this all happens. So decreased prothrombin, they give prothrombin concentrate, factor 8 concentrate, PCC, they give you cryoprecipitate. So based on Rotem, they give you specific blood products. And doing so, this actually accurately and effectively manages your hemorrhage. Okay. So the main thing is many people don't know this exists even in my own hospital. We don't know. I didn't know till the end of my internship. Okay. It might be in your blood banks. If you're studying in a college or working as an intern, go ask in your blood bank if it is present. Okay, so the slide was supposed to come before, but yeah, this is another algorithm. So patient bleeding collapses, ongoing severe bleeding. You're going to call MTP. You're going to activate MTP. You're going to request red blood cells FFP. You're going to give 1 gram of connexamic acid. You have given one packet of massive hemorrhage protocol pack one. So you're going to take blood, you're going to see it's given very small. You're going to take FBC, you're going to take CBC, coagulation profile, urine electrolytes, calcium, all available. If TEG and ROTEM are available, you're going to send ABG, TEG, ROTEM. You're going to make sure you send it. Based on that value, you're going to request another MHP pack, which depends from place to place, criteria to criteria. You're going to get another MHP pack. You're going to transfuse this. So the aim of therapy, make sure your hemoglobin is greater than 8. First thing, platelets are greater than 50,000, more than enough to remember. Hemoglobin should be greater than 8, platelets should be greater than 50,000. Okay, and make sure you check your calcium levels. Calcium levels should be greater than 9, okay, not less than 9. Actually, I don't, its TEG is the machine for rotems, like some other elastography. It's some elastography. I'm not sure what TEG full form is. It's elastography or something. Okay. And then fibrinogen, depending on if you have to give tranexamic acid or FTP, you have to calculate all that. But this three is the criteria. So hemoglobin greater than 8, platelet greater than 50,000, calcium greater than 9, with no massive hemorrhage, you're going to stand down, say MTP is terminated. So this is what you do. Okay. Then guidelines for any massive trauma. So major trauma study, check, apply tourniquets, pelvic binder. Serum calcium is quicker. Adjusted calcium takes time. Albumin measurement takes time. Serum calcium you can depend on. If the patient does not have any side effect or something like that, you don't have to go for adjusted calcium. Serum calcium is dependent, so it doesn't matter. Okay, so this again is another algorithm for management of massive trauma. So major trauma, check, apply tourniquets, pelvic binder. As I said, this is a very important step. Airway control. This is again CABC. Okay, so airway control, assess and resuscitate, keep the patient warm. If you suspect a massive trauma, massive transfusion protocol is suspected. So shock pack 1, shock pack 2, and shock pack 3s are transfused when ready. Patient is patient recognized pattern is done. IO/IV access is secured. Baseline blood groups are taken. 1 gram tranexamic acid is given. Meanwhile, all of this which is ready will be transfused. Okay. While doing massive transfusion, you're going to wait for biochemical storm, or you're going to look out for biochemical storm. If there is hypocalcemia, calcium chloride should be given. Hypokalemia, consider dextrose plus insulin. Meanwhile, what you're going to test, you're going to check rotum, temperature, CBC, clotting factors, urine, that is RLE, and ABG. So you're going to measure all these. You're going to titrate. Don't memorize this, as I already said. This is a bit complex values. Remember this ones: hemoglobin greater than 8, platelet greater than 50,000, and normal calcium levels. Okay. So this is what happens. So this is the termination of protocol, and this is what you do in massive transfusion. This is what you do in massive hemorrhage. What is the definitive treatment for massive hemorrhage? A patient comes, has massive hemorrhage. What is the most definitive treatment? You're going to rule out the root cause. You're going to treat the root cause. This is the major. So if it's a pelvic fracture or femur fracture, you're going to clear the pelvic fracture. You're going to take him to OT. So that is a major thing. You can't do anything more than that. The main root cause to stop hemorrhage is to stop wherever bleeding is happening. That's all. Okay. Then specific situations. So PPH. So postpartum hemorrhage, as I said, it's a very common thing. If you're in final year, you know the 4 T's: tissue thrombus, tone tissue thrombus, and tone tissue thrombus. What is the other one? It's been so long since I read. Tone tissue thrombus. trauma. No, yeah, tone tissue thrombus trauma. So tone tissue thrombus trauma. So tone tissue thrombus trauma. Trauma means cervical tear or the genital canal tear, not major trauma. So these are the most common causes of postpartum hemorrhage. Tone, you're going to do tone specific management, oxytocin infusion, carboprost, and so on and so forth. Tissue removal of retained products of placenta is most commonly done. Thrombus, even they don't know how to manage, they're going to give a medicine call over. And then trauma, they're going to repair cervix. So that's what is going to happen in case of postpartum hemorrhage. Postpartum hemorrhage is where you learn how to manage MTP. The OGCNs are so afraid something will happen. They give a proper, by the textbook management. That is why you actually learn how to transfuse properly. You learn how to transfuse 2 packets of RBCs in 1 hour. So that is where you learn. So whenever you get a chance to visit OGCNs or how they're managing PPH, please make sure you go look at it. The you will never see them that active when they are managing a PPH. So the way they hack, the way they handle themselves, the way they delegate among themselves. One will be having their hand inside, two will be assisting them. One will delegate how much packets you need. One will be calling the blood bank. One will be giving tranexamic acid. The other will be asking to put oxytocin followed by carboprost. So all of this happens together. So management of PPH is an art to watch. If you're getting a chance, make sure you do it. So if there's an intraoperative hemorrhage, what is the most definitive treatment? You're going to make sure you cauterize it. So you're going to cauterize or clamp it, the source of bleeding. So ligate, cauterize, clamp, you're going to do that. That is the main thing. You're going to identify the source, and cauterize, ligate, clamp. You're going to stop the bleeding. That is the main thing. So this is intraoperative hemorrhage. This is usually very rapidly handled because you do have a team of surgeons there. So it's easily handled. Cerebrovascular hemorrhage is very, very rare to cause a massive hemorrhage causing less BP. Rather, it will present with raised ICP signs. That is how a patient with cerebrovascular hemorrhage dies. Damage control resuscitation. So damage control resuscitation is some concept which has been recently introduced. So the main aim of damage control resuscitation is attain hemostasis. That's all. That is the main aim. Attain hemostasis, shift to ICU, watch. That's all. So main thing is attain hemostasis, shift to ICU, watch. So this what happens in damage control resuscitation. You don't need to more about that. Just remember they don't want to do a massive surgery or something. Achieve hemorrhage, achieve hemostasis, shift to ICU, and wait and watch. That's all. Pelvic or femur fracture. The definitive treatment is pelvic fracture surgery, and femur fracture, femur plating or something. Orthopedicians take over. So these are some of the specific situations where you're actually going to deal with hemorrhage. So that's it with the class. So thank you everyone. Kindly fill out the feedback form shared through the chat box. This is going to help us a lot, help me a lot. So see you in my next class on
Recording
21st July
stopped.
based on IoT candidacy. Hope the class was informative today.
Thank you, Dr. Kaushik, for such an insightful session. I'm sure we all learned a lot. Please do fill out the feedback form in the Zoom chat box. Receive the certificate of participation. Please note that the certificates of participation recordings are provided